Dermatology. Dermatology deals with the skin, hair, nails, and sweat glands, and the subcutaneous tissue. And the physician that specializes in dermatology is called a dermatologist. Fun fact: the skin is the largest organ in the body, and it covers a total area of about 20 square feet. It functions to protect the internal organs, dissipate heat, and regulate body temperature, and synthesizes vitamin D when it's exposed to ultraviolet light. It also has sensory receptors that respond to sensations like heat, cold, pain, and pressure. The integumentary system, which is the skin, has sebaceous glands that release sebum, an oily substance that lubricates the skin. The skin ranges from as thin as eyelids to as thick as the palms of the hands. The skin is composed of three layers: the epidermis, which is the thin uppermost layer, the dermis, which is a thicker layer that makes up about 90% of the skin mass and is often referred to as the true skin, the subcutaneous layer, the layer composed of adipose tissue, the epidermis, which is composed of keratinocytes and keratin. Keratinocytes are new cells found in the basal cell of the epidermis. It travels upwards in about 4 weeks, and as they move up, they grow scalier, flatter, and eventually lose their nuclei, changing into dead skin cells that contain keratin. The keratin makes up the outermost layer of the epidermis and forms a protective barrier across the surface of the skin that helps control water loss from the body. Melanin. 95% of the scales are keratinocytes, and 5% are the pigmented cells of the melanocytes. The protein manufactured by the body gives coloring to the skin and protects the body from UV radiation. The skin coloring is not determined by the total number of melanocytes, but by the rate the cells produce the melanin. It also depends on the genetics and the exposure to UV light. For example, albinism. This is an inherited recessive trait that is unable to produce melanin. Individuals have white hair, skin, and lack the pigment in the iris. The dermis. This is a thick layer of the connective tissue that contains collagen and elastin fibers, in addition to water and jelly-like materials that make the skin compressible. Elastin is a flexible fiber that makes skin resilient. Collagen helps prevent the tearing of the skin. They also have sweat glands that are exocrine glands. Epigrin is present over most of the body, and they regulate the body temperature by excreting the water or sweat through the skin pores to release heat. Apocrine, which opens into hair follicles, are located in the axilla, face, scalp, genitalia, and they secrete fatty sweat in response to stress, which is odorless. Subcutaneous. This contains fat cells that provide insulation and serve as a depository for reserved calories. It also contains blood vessels, nerves, and the base of the appendages of skin. It is distributed unevenly, and as the body ages, it thins considerably, which can make drawing more difficult in aging patients. Skin lesions. They can be caused by a systemic problem, like allergic reactions to medication, or may develop from a localized infections. Examples of primary lesions appear immediately, like macules, papules, plaques, cysts, and wheals. Secondary lesions are results of ulcerations in primary lesions, like scales, crusts, and scars. Infections. Bacterial infection, like impetigo, is a common superficial infection that is caused by streptococci or staphylococcus aureus. They usually affect children. It looks like small vesicles on the face that quickly enlarge and rupture and excretes a honey-colored exudate. They usually appear around the nose and the mouth. Itching often accompanies the infection, and the scratching helps spread the lesions at the site. It is contagious and is transmitted by direct contact with the drainage. They recommend constant hand washing to help break the chain of infection. If the area's infection are limited, topical treatment with an antibiotic ointment may be effective. However, if it's caused by streptococci, it may result in glomerulonephritis, which is a more involved infection and may require treatment with oral antibiotics. Acne vulgaris. This begins at puberty, and it's caused by a number of factors like inherited predisposition, hormone fluctuations, exposure to heat and humidity, and the use of oily creams. It is the disorder of the hair follicles and the sebaceous gland unit, and it develops when the sebum reaches the skin surface through the hair follicles and stimulates the follicle walls, causing more rapid shedding of the skin cells. It results as the formation of comedones, like blackheads and whiteheads, pimples, pustules, or larger abscesses at the site. Acne vulgaris. The treatment includes twice daily washes with benzoyl peroxide or salicylic acid. Medicines includes topical antibiotic cream or application of retinoid. You can also use minocycline, which is an extended release drug, and it offers continuous low dose and is used to treat severe acne in patients 12 years or older. The severe cystic acne can be treated with isotretinoin, but it's a strong tetragon and should never be prescribed for pregnant women or women who are not using contraceptives. The use of oral contraceptives also may reduce the acne outbreaks, as well as laser resurfacing. Acne conglobata. This is a severe form of acne and typically occurs later in life and results in lesions across the back, buttocks, thighs, face, and chest. Abscesses or cysts may form between the affected sites, and healing frequently results in keloid formation. The treatment includes a more aggressive treatment with a systemic corticosteroid, oral antibiotics, oral retinoid, and laser resurfacing or debridement to treat excessive scarring. Acne conglobata. Rosacea. This is a chronic disease seen most frequently in women between the ages of 30 and 60. This causes inflammation and pustule formation and begins as frequent flushing across the nose, forehead, cheeks, and chin. As it progresses, the capillaries of the face dilate and are visible across affected areas as small red lines and are accompanied by eye inflammation and photosensitivity. Men with rosacea may develop rhinophthalmia, a large inflamed bulbous nose caused by hyperplasia of the sebaceous nasal tissues. Eventually, they may develop obvious thickening of the skin across the forehead, nose, cheeks, and chin. The condition is treated with the topical antibiotics, and as the symptoms progress, with oral antibiotics like Oracea. This helps produce pimples and bumps on the face, but may not reduce the redness and the flushing. Rosacea. Furuncles and carbuncles. Furuncles is a boil localized staphylococcal infection beginning as an inflammation of a hair follicle or skin gland. Carbuncle is a collection of furuncles that have joined to form a large infected area that may drain through multiple sites or form an abscess. The treatment for both of them are the same, which is oral antibiotics, frequent cleansing of the skin, application of an antibiotic ointment, and or in some cases surgical incision and drainage of the material. Cellulitis. This is an acute infection of the skin and subcutaneous tissue caused by staphylococci or streptococci. This begins from a small cut or result of a skin injury, or develops at the site of a furuncle ulcer. The area surrounding the site becomes inflamed and mattrous and painful with the red streaks along the lymph vessels that lead from the infection. The treatment includes oral antibiotics. Patients need to be treated appropriately because the systemic infection can develop if the lymph glands become involved. Fungal infections or dermatology. Fungal infections or mycotic infections like tinea pedis, athlete's foot, tinea cutis, jock itch, and tinea corporis, ringworm, are extremely common. These pathogens tend to live off dead tissue in the keratin layer of the epidermis, hair, nails, and cause almost no inflammation in the underlying skin. The fungus invades the skin where it's been damaged or is constantly moist. All lesions are pleuritic and characterized by distinct disorder with scaling areas that have a clear center. The treatment includes topical antifungal agents like mycostatin. Tinea unguiculum, or onychomycosis, is a fungal infection of the toenails and fingernails. This lives in the nail bed and in the nail plate. The primary sign of nail fungus appears in the nail that turns yellow, white, or opaque. The texture becomes thick and brown, and if it's present for a long time, the nail can become twisted or distorted. The most effective treatment includes oral terpenicillin, hydrochloride, or Lamisil, and others. The drug must be taken 6 weeks for fungal infection of the fingernail and 12 weeks for infection of a toenail. Tinea pedis, tinea corpus, and tinea unguiculum. Warts. Verrucous is caused by human papillomavirus, or HPV. The infection of HPV results in hyperplasia of the epidermis and a raised cauliflower-like appearance. The most common sites are the fingers and the soles, which is the parental warts. Most warts resolve over time, but they can be treated with topical chemicals, vaporized with layers, or removed with cryosurgery. Herpes simplex, or cold sores. These are fever blisters caused by herpes simplex virus type 1. The initial infection may be asymptomatic or cause painful ulcers along the gum lines of the mouth or on the lips. After the primary infection, the virus remains dormant in the trigeminal nerve and can be reactivated by the exposure to the sun or to cold, presence of another infection, or when the patient is under stress. Symptoms include burning, tingling, or numbness before the eruption of vesicles. The blisters usually heal up to 2 to 3 weeks, but you can speed it up by the use of topical antiviral drugs. Herpes zosters, or shingles. This is an acute inflammatory disorder characterized by highly painful vesicular eruptions on the trunk of the body and sometimes the face. The lesions develop on one side of the body and follow the course of the peripheral nerve, or dermatome, that has been affected by the varicella virus, the same virus that causes chickenpox. The virus lies dormant in the dorsal root ganglia and reactivated in later years. The onset of this disorder is marked by pain along the nerve pathway and appears in approximately 3 days. The inflammation lasts 10 days to 5 weeks. The symptoms include the complaining of burning or tingling, pain, or numbness or itching on one side of the body. The most common location for shingles is on the band of the trunk around the waistline. The treatment includes analgesic and antipyretic medications like corticosteroid medications and antiviral medications. One of the most serious complications is postherpetic neuralgia. This causes chronic pain after the resolution of the initial outbreak. This may require treatment that is with a combination of medications, including lidocaine skin patches, narcotics, antidepressants, and anticonvulsant medications. Vaccines to prevent shingles include the chickenpox varicella virus that is given to babies 12 to 18 months old and to older children and adults who have not had chickenpox. This vaccine reduces the risk and severity of both chickenpox and shingles. The herpes zoster virus that is recommended for 60 years or older, regardless of whether they have had shingles. These vaccines do not guarantee protections against shingles, but can reduce the duration and severity of the outbreak and help prevent postherpetic neuralgia. Parasites. the itch mite that causes scabies, and the lice that cause PD. They are common parasites and highly contagious. The scabby mites are tiny organisms that burrow into the epidermis. The diagnosis may require the scraping of the skin at the inflamed area and the examination of the mites under a low-power microscope. The symptoms include intense itching, a possible rash, and a sensation of something crawling on the skin. Usually there is no symptoms for the first 2 to 6 weeks of the scabies infestation. The treatment includes ridding the body of the parasite, controlling the pruritus, and disinfecting the home environment to prevent reinfestation. It is recommended for all household members and sexual contacts in the past month, and should be treated at the same time to prevent the reinfestation. No OTC products have been approved for the treatment, so there must be a prescription. This is treated with a single application of 5% elamite or Urax creams all over the body from the neck down. It is typically applied before bedtime and should be left on for a minimum of 8 hours, repeated in 7 to 10 days to destroy the nits or the eggs. Pediochlosis is an infestation with lice that can be caused by different types of lice: head lice, body lice, and pubic lice. Inflammatory skin disorders. Seborrheic dermatitis. This is one of the most common chronic inflammatory conditions of the sebaceous glands. It alters the amount of quality of sebum, resulting in dry or moist, greasy appearing scales and yellowish pus on the scalp, eyebrows, eyelids, and the sides of the nose, behind the ears, and in the middle of the chest. The different forms include the cradle cap in infants and the dandruff in adults. It is treated with tar or sulfur-based shampoos. Inflammations of the skin are usually treated with topical corticosteroids such as generic diacetyl or betamethasone, balstilimab, and etc. Seborrheic keratosis or H-spot is characterized by benign, slightly raised tan to black lesions that can occur with aging. Contact dermatitis is an acute inflammatory response to a skin irritant or form exposure to a substance that causes an allergic reaction. Individuals allergic to latex gloves or who has been exposed to poison ivy shows the signs and symptoms of complaints of redness, edema, pruritus, and vesicles. The patient should be encouraged to wash the affected area immediately after exposure, and the treatment includes the application of corticosteroid cream or the use of oral corticosteroid medications. Eczema. This is an idiopathic inflammatory skin disease that tends to occur in patients with a family history of allergies. It can occur in young children caused by food allergies, older children caused by stress or temperature extremes that can trigger flare-ups. The condition usually improves and may disappear as a child ages. It is characterized by a fascicular rash on the face, neck, and elbows, and behind the knees and the ears. It causes pronounced pruritus that, if left untreated, it results in expiration of the affected area from the constant scratching, and it is non-contagious. The goal of the treatment is to reduce the frequency and the number of eruptions and to relieve the pruritus so the affected areas do not become excoriated. The primary inflammation is treated with the topical corticosteroids and oral antihistamines. The provider may recommend controlled exposure to sunlight or UV rays to prevent and treat outbreaks. Psoralins are light-sensitive drugs that can absorb ultraviolet light and are combined with UVA to treat skin conditions like eczema and psoriasis. Inflammation of eczema plaques typically indicates a secondary staphylococcal infection and can be treated with an oral antibiotic. Autoimmune disorders. Psoriasis is a chronic skin disease that produces discrete pink or red lesions covered with silvery scales. The most patients develop the problem before age 40. And most infections is characterized by periodic flare-ups throughout the life and is caused by autoimmune reaction that speeds up the maturation rate of the skin cells. The normal skin cells mature, die, and are shed every 28 to 30 days, but with psoriasis, the cells mature in 3 to 6 days, and instead of coming off of the skin, they build up and form the classic psoriasis silvery patch. It is diagnosed with the observation of the skin and a careful patient history because of the familial link that has been established. And the treatment is palliative because the disease has no cure. Systemic lupus erythematosus. This is a chronic autoimmune inflammatory disease of the connective tissue. The cause is unknown, and although women are 10 times more likely to develop the disease than men, it causes inflammatory changes in the skin, joints, muscles, and kidneys, and the patients experience periods of exudation and remission. It's diagnosed by its signature butterfly-shaped rash that stretches from one cheek across the nose to the other cheek. Other integumentary system symptoms include erythematosus, patches, and plaques, alopecia, and photosensitivity. The prognosis depends on the organ development, and the treatment includes NSAIDs, including ibuprofen, or controlled low doses of corticosteroid. Serious cases are treated with cytotoxic drugs and anti-malarial drugs. Thermal injuries. Superficial burn affects only the epidermis and is erythemic, which is red, and blanches with pressure. It is painful but does not have blisters at the site, for example, a mild sunburn. A partial thickness burn destroys the entire epidermal layer and the varying depth of the dermis, and causes blister formation and the subcutaneous edema and pain. If it's deep enough, some destruction of the hair follicles and the sebaceous glands may occur. A full-thickness burn destroys all the layers of the skin and may involve underlying fat, muscle, nerves, blood supply, and bone. The area appears charred or white and has a firm leathery texture, and the patient feels no pain because the nerve endings have been totally destroyed. It can cause major complications like dehydration, circulatory collapse, respiratory distress, and septic shock. The treatment includes maintaining the patient's airways, replacing fluids, preventing infection, and administering oxygen. The debridement of affected tissue includes the areas of eschar and the skin grafts, which are required for wound healing. The burns are classified according to the percentage of the body surface involved, and is based off the rule of nines. The body is divided into equal sections of about 9%. A partial thickness burn over 15% of the total body surface and a full thickness burn of less than 2% can be treated in the ambulatory care setting if the patient is seen stat or immediately. Patients with larger body surface area involvement or other complications should be transported immediately to a hospital. The treatment of minor burns includes preventing the infection at the site that is a primary concern. The superficial thickness burns typically heal on their own within a week, as long as they are kept clean and no infection. Partial thickness burns treatment includes dental cleansing of the site with a bacterial solution and the debridement of broken blisters or dead skin. The intact blisters should be left alone. The partial thickness burns may be treated with a thin layer of silver sulfodiazine cream and the application of a non-adherent multi-layer dressing for several days to 1 week. The tetanus immunization status should be reviewed and it should be given if needed. Cold injuries are less severe than burns, but can be prolonged exposure to cold temperatures and can result in infection, gangrene, amputation, and in severe cases death. Frostbite is caused by the exposure to sub-freezing temperatures. The damage occurs at the low level of the capillaries, which can become permanently dilated and unable to regulate local blood flow. The signs and symptoms include burning, tingling, numbness, and a white or grayish color of the skin. With deep frostbite, the blisters form and the area is hard, mold, and matulous, and blue or gray after thawing. The treatment includes warming the area with immersion in warm water 100 to 106 degrees Fahrenheit. It should never be rubbed because this increases circular destruction. Benign and malignant neoplasms. Abnormal growth or tumor that can be benign or malignant. Invasion and metastasis are the principal criteria and can be used to distinguish between cancerous and non-cancerous tumors. The benign masses are encapsulated, and although they may increase in size, they remain confined with the shell. Malignant tumors invade and take over surrounding tissues. The local invasion of the surrounding tissues occurs when the malignant cells break through the basement membrane that separates the epithelial cells from the connective tissue. The cancerous cells can invade blood and lymph vessels, which carry the malignant cells to the organs. The patients diagnosed with carcinoma in situ have a malignant tumor that is confined to the original site of growth without invasion of the basement membrane. The patients with regional spread have evidence of malignant cells in surrounding tissues, but no evidence of lymph node involvement. The patients with distant spread or metastasis show lymph node involvement locally and the development of secondary tumors in the other organs, including the liver, brain, or bones. Examines the cell under the microscope and grades the sample according to the histologic or cellular classification of differentiation. The differentiation is the process that the normal cells go through to mature. Immature or primitive cells that never mature are anaplastic or cancerous. If it's cancerous, the next step is to determine whether the cancerous cells have spread from the original site, and this is called staging the tumor. You could use physical examination and diagnostic tests. They are done to determine the degree of the tumor spread to the secondary location. The size and the depth of the primary tumor, the degree of the lymph node involvement, and the presence of a metastatic spread determine whether the patient has carcinoma in situ. The three methods for obtaining the tissue include the excision biopsy, which is a removal of a mole, the punch biopsy, which is a removal of the small section from the designated location in the lesion, a shave biopsy, which is performed with a scalpel or razor by cutting or shaving off the growth or lesion for a thin specimen of combined epidermis or an upper dermis cell. Possible treatments include the surgical removal of the tumor, radiation therapy, chemotherapy, hormone therapy, and immune system boosters. All this is determined by oncologists and a physician specialist in the study and the treatment of cancer. The neoplasm in the skin may be benign or malignant. An example of the benign tumors include birthmarks and moles, like Movavi. However, a tumor may be benign but have a predisposition to be cancerous, which means that it can change from a benign state to a malignant. The three cancerous lesions of the skin can occur: basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. The basal cell lines the deepest layer of the epidermis. It is very slow growing, most frequently seen form of cancer. The most common sites are the areas of the body exposed to the sun, like the face and the forearms. It can also appear as a persistent sore with a reddish irritated appearance that does not heal. The squamous cell carcinoma grows rapidly and is more serious because it has a tendency to metastasize. It appears firm, red nodule with visible scars, and may ulcerate and form a crust. Both the basal and squamous cell skin cancers are sores that persist and never heal. The malignant melanoma develops from a change in the mole. The sunburns increase the risk of melanoma, and individuals with the genital nevi, or moles that are present at birth, are more likely to have melanoma. A microscopic surgical procedure, Mohs surgery, is an effective, precise method for treating and removing basal and squamous cell carcinoma. These are performed by specially trained dermatologists by the use of the microscope to systematically trace the cancerous lesion down to its roots and remove the tumor layer by layer. This minimizes the chance of regrowth to reduce scar formation. Assisting with the dermatologic examination. It occurs a dermatologic examination provider inspects the entire body from the scalp into the soles, including the genital area. They use palpation, diascopy, and special tests. Diascope is a glass plate held firmly against the skin to permit observation of changes produced when the pressure is applied. The dermatologist asks the inmate to take photographs of the moles or to document specific measurements and the location of suspicious lesions. In the physical examination, Concerns include abnormal coloring such as cyanosis, pallor, erythema, leukocytes. Lesions, ulcers, and bruises may be the result of pathologic conditions, localized red or purple changes caused by vesicular neoplasms, birthmarks, or subcutaneous hemorrhages. Skin testing for allergy. Percutaneous or scratch test is performed on the forearm, upper arm, or the back, and is favored on young children because of the large area of the skin available. The skin surface is labeled or numbered in rows 2 inches apart. The allergist uses a plastic device that is dipped into the designed allergens and lightly pressed into the skin so that the prick and allergen deposition occur at the same time. 70 or more tests may be done at one time. It is essential to follow a pattern. It is used for the allergic rhinitis, asthma, and detection of food allergens. The reaction usually occurs within 10 to 30 minutes of exposure to the allergen. If it's positive, a wheal forms at the site of the scratch. The interpretation of the test should always be based on the comparison. It is performed by a provider or a trained technician, and the reactions are greater than 2 to 4. If a strong reaction occurs, the allergen extraction is carefully wiped off to prevent any further exposure. The patient should remain in the office for at least 30 minutes after the completion of the test. Patch test uses allergens that is applied to the patch placed on the skin. The patch test helps detect delayed allergic reactions associated with contact dermatitis. The patches are placed on the arms or back and must remain in place for 48 hours. The skin irritation at the patch site indicates an allergy. The patient needs to avoid bathing and activities that can cause heavy sweating. The intradermal test is more sensitive than the percutaneous test and is usually used to diagnose allergies to penicillin and insect venom like bee sting. The extracts are injected into the intradermal layer of the skin in doses of 0.1 to 0.2 milliliters. When the intradermal injections are used for allergy testing, 10 to 15 allergens may be used at one time on each arm. Radioallergen absorbance test, or the RAS test, measures the level of antibodies created when a sample of the patient's blood is mixed with the allergens. It requires a single venipuncture, and the RAS may be indicated when the patient cannot stop antihistamine medication, when a skin disorder makes accurate interpretation of skin test results difficult, when the skin test results are negative but the patient's signs and symptoms support further investigation. The RAS blood tests are primarily used to identify food allergies. The treatment of allergies is used to encourage the patient to avoid known or suspected allergies. Unfortunately, this is not always possible, so the provider may prescribe antihistamine medication. Immunotherapy is a series of injections in which the minute dose of known allergens are described subcutaneously over time to desensitize the patient's immune system and ultimately develop a resistance to the immune response. It usually requires weekly or bi-monthly injections over several years. The patients are cured, whereas others have only a minor reduction in allergic symptoms. Immunotherapy is controversial because it is expensive, invasive, and potentially dangerous. The treatment is also unpredictable results. A chemical peel is a topical agent that are used in chemical peels to minimize or remove minor skin features such as acne, scars, hyperpigmentation, and fine wrinkles. The agents chemical peels use include tetradenoate cream, which is 0.05% to 0.1% concentration, and different acidic preparation. You should avoid sun exposure for length of treatment and should use sunscreen with a minimum SPF of 15 because photophobia, light sensitivity, is a typical side effect. Dermabrasion. This is a handheld device that mechanically evens the layers of the dermal tissue. It is effective in the treatment of scars from acne vulgaris. and the topical anesthetics or locally injected anesthetics besides dermabrasion. The dermatologist may use a variety of wire brushes, abrasive discs, or other devices to smooth scar tissue. Make sure to educate the patient about wound care, signs of infection, and the presence of photophobia for 6 to 12 months after the procedure. Laser resurfacing is a laser therapy that may be used for fine lines and wrinkles, pigmented areas, shallow scars, and tattoo removal. Patient is instructed to prepare the site 3 to 6 weeks before the procedure with tetraquinone alpha hydroxy solution or bleaches. After the procedure, cool packs are applied to help reduce swelling, and topical antibiotic cream is used to prevent infection. The treated area appears inflamed and edematous and can take up to 2 weeks to heal. It can take as long as 6 months for the inflammation to fade. Botox injections are a strong neurotoxin that is produced by Clostridium botulinum, a bacteria that causes food poisoning. The Botox treatments involve injections of the substance around the eyes, mouth, and forehead. The toxin interferes with nervous stimulation, which temporarily paralyzes the muscles of the face that causes wrinkles to form. The effects are also short-term.